All right, welcome everyone. Thank you for joining us. And I'm really excited here tonight. We have Dr. Edward on. He is out at Mayo Clinic. The first thing I do usually is ask the clinicians to kind of introduce themselves, talk about why they got involved in Chiari Syringomyelia care. But I did want to just quickly ask a little bit about because you had attended most recently our Bobby Jones Classic at Eastlake in Atlanta. So I just wanted to first get your thoughts on how that was, what you liked about it, maybe something that you would change in the future, because we're actually starting to plan our next event, which should be at Sea Island Resort, also in Georgia, I believe. But just wanted your thoughts on that golf tournament and how you felt about it before we got started.
Yeah, I think the Bobby Jones Classic is a perfect marriage of my two loves, and that is my interest in Chiari malformation and Syringomyelia, and then golf. And it's how I pretty much spend all of my free time that I have. So that event, I look forward to it every year. And I truly am inspired when I go to see how many people come out and support and how enthusiastic they are. The venue is always like, you can't argue against that. Having the tournament out at East Lake and being able to connect with folks down there. We love the town of Atlanta, and I bring my family out. We make a weekend out of it. So, in terms of things to improve, I really can't think of anything. I think this is just an amazing event, and so not too helpful from that standpoint. I just say keep doing what you're doing, and I know you're going to change venues next year because of renovations to East Lake, but I think the spirit is still going to be there, and I really hope for success and continuation of supporting this cause. And it's really connected me with a lot of interesting folks, including Bob Jones, who's the grandson of Bobby Jones, and people who just love golf. And it just, we find an immediate connection between my family and theirs. But then more so, I love it when people find out that I'm a clinician who treats this disorder and they want to know more about it. And it's really, becoming something that's on the map for them in terms of things that they think about, because undoubtedly they have that connection obviously with Bobby Jones, who historically had the disorder, but then probably someone that they know has it. So I really see it hit home for them. So it's a complete joy for me. I actually end up learning a lot from the the session before the golf tournament too. So I really had a good time with the historical perspective um, of looking at Bobby Jones's life, and I really enjoyed that. So yeah, I'd say yeah, keep doing what you're doing.
Thank you. Awesome. Thank you. I know that was a little bit, I just wanted to sneak that in there. But with that, I did want to get this rolling. So what I usually do is I'll have you sort of introduce yourself, talk about why you got involved in Chiari and Syringomyelia kind of surgeries, how that happened naturally or unnaturally maybe. And then I'll have you do your presentation. I'm gonna pop away during this time and I'll come back on. We'll do the Q&A session immediately after. So I guess we'll start right there.
Okay. Yeah. So, I mean, I guess I could start with my presentation because it'll kind of get into how I got involved. I'll tell a little bit about myself. I think, let's see, let me show you some slides here. Okay. Yeah. So, I'll tell you about myself. Let's see if I can advance forward here. So I'm originally from Baltimore, and this is the Johns Hopkins Hospital. So I had the privilege of doing some of my medical training there, and then practicing there as a pediatric neurosurgeon for 11 years. And so this is still considered home for me. And when I first started out, I was under the initially as a resident under the tutelage of Ben Carson, and when I joined the faculty, I joined with him, and he was the director of pediatric neurosurgery when I started. So this is a picture of Dr. Carson and I doing an operation together. during my time as faculty there. So that there was just some really memorable years. And the other pediatric neurosurgeon at that time was George Jallow. And during my time in practice in 2010, I had been treating pediatric Chiari malformations for quite some time. And then we had interestingly enough, a professional golfer come who was just diagnosed with a Chiari malformation, and it was someone that I had been following and was really enthusiastic about. And he came to get treated by Dr. Jallow, and I helped Dr. Jallow with his operation, and that got me even more inspired about seeing what he had gone through and seeing how he had to recover from it. And he was able to return back to professional golf after that, but I think never sort of reached the pinnacle of what he had envisioned. And I thought that we have a lot of things we need to do for this malformation, which actually is fairly common. And when I saw that it sort of hit that professional golf world, I realized that, man, we need to if they came to what I thought is one of the best places to get treated for this, and still the road to recovery was pretty long for him. I thought that we still have a lot to do. So that's when I really started dedicating a lot of time to thinking about it. Um, After my time at Johns Hopkins, I then in 2018 moved to the Mayo Clinic. These are two of my partners who helped me in pediatric neurosurgery. And with that move, there was probably even more of a focus on Chiari malformation. We here at Mayo um, have the uh, have the distinct pleasure to really focus on things that we want to focus on, and our practices can really be specialized. So Chiari malformation is one of those things that I've really, over the past 4 or 5 years, really dug down deep. And I'm going to go over some of the things that we've discovered and some of the things that we've looked at in the past couple of years with regard to this. So I've had the pleasure of practicing out here. It's a great place. Beautiful time of year coming around the corner. We're just getting warm now, and just want to thank all you guys for being here on what's looking like a good spring day for most of us here in the country. All right, so that's our team there. That's the Mayo Clinic. That's about me. And what I wanted to do is just spend probably the first half of our time together just going through some material about Chiari malformation, with the understanding that those of you probably have some background information, have experienced, delved into it to some depth. So I didn't want to get too much into the basics, but just wanted to review some things, then talk about some of the latest things that have come out of our research here at Mayo, and then also kind of nationwide too. Some of the things that people have been working on with big data, with big numbers, and what's being looked at in terms of the latest research. So to begin, the Chiari malformation is a disorder of the hindbrain, or the back of the brain. So it's involving the cerebellum, which is typically involved with things like coordination and balance, among a lot of other things. And the issue with the Chiari malformation is that part of the cerebellum is outside of the head. So the primary reason people think about this in a standard, most common Chiari malformation situation, is that the place for the cerebellum, or the housing for the cerebellum in the back of the skull, is too small. And so because of that, part of it extends outside of the head. And in this diagram in the bottom right, you can imagine some of the things that might go wrong if something like this happens. The first thing is that there is a very sensitive membrane called the dura that surrounds the brain, and it has a lot of nerve endings on it. And probably the most common type of symptom that people get is pain. Pain in the back of the head, typically right around this area, is very common. And anything that when we look at a picture of the brain, we always think of like a still image, but I'll show you some pictures later that the brain is not a still image. It's a constantly sort of pulsating organ with every heartbeat. There's changes, right? And there's changes with activity. So in a situation where one is doing a strenuous activity or bearing down, such as when they're coughing or sneezing, the brain changes and it can actually fill that space very quickly and cause pain because the covering over top of the brain has a lot of sensitive nerve endings on it. So that's the most common type of thing, and that's the most common reason for as a pediatric neurosurgeon that kids find out they have this, and they usually come with that complaint, and it's often the most common reason that we would suggest some kind of surgical treatment for it. Other things that could happen in the pediatric population are an effect on the other part of the brain right in front of the cerebellum, and that is the brain stem. And the brain stem, among other things, carries all the signals down to the arms and legs. And the other thing that it does is it houses control of the throat. So you can imagine how there are a number of nerve signals that come from this part of the brain and go to the muscles of the throat and coordinate swallowing and breathing. And in some rare circumstances, we can see children born with a Chiari malformation, and then the way they come to our attention is that several years later they're just having this chronic issue with either swallowing disorder, with sleep disorders, namely sleep apnea. So those are some other common things that can happen with the Chiari malformation. So those are common symptoms, and hopefully this is a kind of a refresher for those of you who are familiar with this type of what's happening anatomically. The person who coined this malformation is Hans Chiari. He was an Austrian pathologist, noted the malformation, and therefore it bears his name. It's most commonly diagnosed by MRI. So on the left side, we have a normal MRI. So if you can imagine that diagram that you'd seen previously in the back of the brain is that cerebellum, which is nicely tucked inside the head. In a Chiari malformation, you do not see that space around the cerebellum. So on the right side, in this situation, there's no space around it. There's none of that black fluid around the brain. And this is really compact and taking up a lot of space. And in this patient came to us with complaints of severe headache in the back of the head. And you can now see why. This thing just takes up a lot of space there, and there's really no wiggle room at all. The MRI scans often, when they're looking at a Chiari malformation, if that's moving appropriately for you guys, you can see pulsations. So when I talked about the brain being a dynamic object, with every heartbeat, there's pulsations of the brain and also of cerebral spinal fluid around the brain. And in this circumstance, this is a normal situation where you have cerebral spinal fluid sort of pulsating all around the brain at where the head connects to the neck. Contrast this with someone who has a Chiari malformation, and this is an abnormal situation where something is really plugging that outlet of the head, and there's no room for the fluid to circulate around the brain. So you can see how this would cause problems because really there's a blockage there. This is called a Cine study, and sometimes people use this when they're doing MRI scans. I don't use it all the time, but sometimes this can illustrate the issue there. The other issue is the other half of the foundation name is Syringomyelia. So the short name for this is Syrinx. So we say Syrinx just for short, but basically a Syringomyelia is a collection of fluid within the spinal cord. Harking back to Bobby Jones, this is what was thought that he had, and caused a disorder that stopped him from playing and walking and eventually becoming wheelchair bound. So this is a collection of fluid in the spinal cord, and we believe this is directly related in these cases to the Chiari malformation. A lot of theories as to why this develops, but the simplest answer that I can come up with is a theory by a man named Gardner, and basically it's the idea that there should be normal circulation of fluid around the brain, and then that communicates with the fluid in the spinal cord, and that is blocked by a Chiari malformation. So if the Chiari develops there, the fluid has nowhere to go. And with each of those pulsations that we were seeing on that MRI, the fluid just builds up inside the spinal cord. So that's a disorder that could really cause dysfunction of the spine, dysfunction of the spinal cord. So see, these are some cross sections of a spinal cord with the syrinx within it. So you can see kind of like a cavity that's built up inside the spinal cord. The first thing to go in terms of weakness with this is weakness of the hands. It tends to affect the part of the spinal cord that controls the hands. So if we're going to see any weakness, it usually starts with this, or it could cause a numbness and sort of that distribution of your shoulder down to your arms and down to your hands. But I've seen some situations where a child will have weakness of one or two hands and not have any idea why, and it gradually gets worse, and they're found to have a Chiari malformation. They didn't have any other symptoms before that, but just the progressive weakness of the hands. So what the syrinx looks like on an MRI is this. This is a normal MRI on the left. In this particular MRI, all the fluid is white. So you see plenty of fluid around the brainstem, plenty of fluid around the cerebellum. And in this situation, this is a person who's developed a very large syrinx where essentially the entire spinal cord is taken up by the fluid. And you can see how it just looks like it's all blown out by the fluid. And surprisingly, this young lady was completely intact neurologically, was able to move everything with full strength, just because it built up really slowly over time. But this is how severe it got before she got to attention. So that's a pretty severe case of syringomyelia. So I'm going to talk a little bit about, before we talk about any type of treatment, talk about what happens if this is discovered. Let's say a Chiari is discovered, and what happens over time with the Chiari. Let's say nothing were to be done for treatment. And this has been looked at by a colleague of mine, Dr. Maher, who is currently at Stanford Children's Hospital. And he looked at kids who would come in for a Chiari malformation, get a scan done, and then later on got another scan, got another MRI. And the question was, does this change over time? And the answer is yes, it does. Most of the time it stays the same, but it can change. Does it get better or worse? And the answer is both. It gets better and worse in people. So this is a graph of people who've gotten 2 MRI scans with the Chiari malformation, and they're measuring how much the Chiari malformation extends outside the brain, or excuse me, outside of the head. And you can see in the majority of children who had MRI scans, 60% of them roughly had no change between their MRI scans. So there's 0 difference. But then you can see that people could have both situations. It could get better, which is the negative, or it could get worse, which is the positive. So the answer is that it does change with time, that children are growing, that things are constantly sort of changing between their head and their neck, and that you can see changes at least 40% of the time with a Chiari malformation. The problem is that, whenever I'm sort of counseling a family with regard to what to expect in the future, I just don't know the answer. I don't know which way it's going to go. So there's probably some room for discovery here in terms of predicting if it's going to get better or worse. These are some situations of children who actually showed some worsening. So the first 2 pictures are MRI scans of the same individual, and that person had a Chiari malformation discovered, and the spine looked pretty good. Didn't see anything, didn't see any syringomyelia in the spine. But then later, this is 4 years later, the Chiari malformation got worse, and you can actually start to see that pocket of fluid build up in the spinal cord. Similar situation with these next 3 studies here. This is a patient who had a Chiari malformation. Again, the spinal cord looks pretty good. And then 4 years later, you can see a pop-up of a new syrinx or syringomyelia just developing, and then the patient went on to get surgery, and then the syringomyelia went away. So just to show you that there can be some worsening over time just because kids change and grow. Are there situations where it can get better? We do know the answer, yes. So the answer is yes. So how so? I've seen certainly cases over time in my experience. This is a child that I had observed. So this is an MRI done when he was 9 years old. He had a seizure. He did have some generalized headaches at that time and got an MRI, shows a Chiari malformation. And then 7 years later, he's having some persistent headaches and then had some new symptoms. But then when they did the MRI scan, the Chiari was gone. So between the ages of 9 and 16, that Chiari went away. There were enough changes back there, enough space made that the natural history, so to speak, was better, that it got better with time without doing anything. This is another child who was 9 years old. He came in with a curvature of his spine. He had scoliosis. And interestingly enough, in this situation, most of the time with scoliosis, we would recommend something to do something about that Chiari malformation, because especially if it gets to the point where the spine is curving. But for whatever reason, the parents said, no, we're not going to do anything about it. No surgery. And then he came back 5 years later. He still had some scoliosis, and he was getting a brace. But then when the MRI was done, really the Chiari malformation cured itself. It was gone, and then the Syringomyelia was gone. So this is a situation where, yes, it can get better with time. We just don't know. When they first come in, we don't know what direction they're going to go. But there's certainly some circumstances where it can get better. Okay, so then we'll move on to talk about surgery, all right? And if we do recommend surgery, I'll go through some of the things that we think about. This is a depiction of an exposure of the back of the head. So our goal is to make room for the Chiari malformation. We do that partially by removing the back part of the skull, or the occipital bone, we call it, and we cut away some of that bone in order to relieve that compression. This is an approach showing the standard lines that are made. So there's an incision that's usually made from what we call the inion of the head. It's basically a little notch. If you kind of feel the back of your head, that's where we start. And then the incision is made down to bridge and expose the very top of the spine, which is the level C1. So the incision's made, and then those elements of the bone are exposed. So it's the very bottom of the skull, very first bone of the spine, and then those segments of bone are removed, and then often the surgeon can then decide whether they're going to expand the covering over top of the brain. So that's the incision. The incision looks like this. These are just pulled off of Google, and these are patients who had that Chiari operation. You can see the incision going up and down there. I did treat this malformation for years, and I've always wondered, is there anything we could do better about that incision? I understand that, this is a brain condition, and, important things are important things, that, we want to cure the brain condition most of all. But boy, when all is said and done, you could still see that incision. So this is, again, pulled off Google. This is a girl who had a Chiari surgery, and you can see how the incision standardly is up there in the head, but also extends down to the neck. And I thought about that, because every time I saw the patients back, I think, everything's good and they're doing great, but man, I wish we could do something about better about that incision. Of course, some people just kind of have fun with it. This is also pulled off of Google, and you can see the incision, and people are having fun with tattoos there. But regardless, several years ago, I came up with the thought that, well, what if we were to hide that incision in the hair? That seems feasible, that we can do the same surgery, but with a less obvious type of incision. So several years ago, I thought about, well, what if we took the incision and turned it on its side? And that allows the surgeon to do what they need to do with the same exposure. But I'll show you later that we're able to hide that incision a lot better. So, it's essentially a cosmetic thing, and I understand that. But, oftentimes I've noticed over the past couple of years of doing this that it really does make a difference if we could do the same thing with less of a scar. So we published this work just recently, and we call it the above the hairline transverse approach. And we had a series of kids who came in, and we did this incision where we made it turn on its side, and we hid it within the hair, and we've been happy with that. So this is the standard type of approach that we would do, but instead we turn it on its side, and with that we were still able to get the exposure that we need. We could see the bottom of the skull here and the top of the spine, and it doesn't really restrict our approach at all. And then even with the duroplasty, which is expanding the covering over top of the brain, that's done without any problem through this type of incision. And just some of the results that we've seen over the past few years, we have this incision here. Of course, I cut the hair when I do the surgery, but then when the hair grows back, it's nicely hidden there above the hairline, which is a big bonus there. So some of these are really invisible. This is a boy who has short hair, and you can barely see the incision there about 3 months later. This is another recent surgery that we did. So a boy who has short hair is just nicely hidden there. So just another touch, I think, which I think makes the kids and the families happy. Um, our goal with the surgery is to really make more room for the operation, for the Chiari malformation. And with this operation, we remove segments of bone. So this is the MRI of the spine. We take away the very first segment of the spine in the back, which is called C1, and we take away a very small segment of the skull, and then we expand that area. So if you look at this MRI that was done before surgery, you can see that things are very crowded in there, and then you see development of a syringomyelia, and then after the surgery that goes away. So that's to be expected afterwards. So a nice decompression and relieving the syringomyelia. I'll talk a little bit about duroplasty. Duroplasty is a topic of recent research, especially with a lot of numbers. We're really concentrating among different centers to look at the effect of this. And this is a surgical step. It's basically after the bone is removed, we do another step where we open the covering over top of the brain, and then we sew in various materials in order to expand that area. And traditionally surgeons have done this, but then some surgeons have not done it, and it's a question of what's better. So that's the duroplasty, and this is just to kind of give you an update on some of the things that the surgeons are talking about in terms of is this really necessary. And some of the initial look at this has been at like one hospital. So for example, here's a group in St. Louis. Look at their experience at the St. Louis Children's Hospital of looking at patients who had that duroplasty and who did not have the duroplasty. And in this study, I'll just kind of briefly read through it. This is 36 patients who had the duroplasty and 29 patients who did not have the duroplasty. Again, this is just at one hospital among the same group of surgeons. They found that without the duroplasty, that the surgery operation time was shorter, and the time that the patient spent in the hospital was shorter. But with the duroplasty, I found that there were more complications. Not too much of a surprise. I mean, you're opening over top of the brain, and you may have some cerebral spinal fluid complications. That has to do mainly with the fluid that surrounds the brain. And they said that the improvement between the two groups is around the same. So what they argue from this study was that you can achieve similar type of results without going through that extra step. Of course, this was a limited number of patients, so you really had to expand that. And what's been developing over the past several years is research coming out of the Park Reef Syringomyelia Research Consortium, and this is basically a conglomerate of a number of children's centers that are looking at a lot of patients who have syringomyelia, and some good things are coming out of that, and I'll kind of give you an update of some of the research. The first thing is, what about scoliosis? So what if, does that make any difference whether you do that step, the duroplasty or not, versus how scoliosis changes? So they looked at people who had Chiari malformation and scoliosis, and then those who underwent surgery for their Chiari malformation. And they found that there was no difference between groups in eventual need for surgery. So basically, whether they did the duroplasty or not, it didn't make any difference whether they were going to need scoliosis surgery or not, right? So there was no benefit in that sense. But really, when you broke it down to matching the patients with how a lot of other preoperative factors, like how severe the curve was, their age, and so on and so forth, they did find that the duroplasty patients did better. So when you matched them head to head, and you found that there was an advantage to doing the duroplasty, the curves actually did not progress as much in that group. So some interesting findings having to do with scoliosis. The other one had to do with surgical complications, right? So but looking at, again, a large number of patients and looking at how frequently they had surgical complications, right? So this was a review of people who had Chiari malformation undergoing surgery for and who had Syringomyelia, and nearly 700 patients. So here we're talking about real numbers, big numbers. So the findings that from that study was that without doing the duroplasty, so you just remove the bone and then that's it, that this reduced the time in the operation and reduced blood loss. They stayed in the hospital shorter and reduced the complication rate within 6 months. So overall looks pretty good. However, the patients who got the duroplasty, and again, this is all patients with syrinx, they were found that they had better symptom improvement, reduction in syrinx size, and lower rates of revision decompression. So 8 versus 18%. So only 8% of these patients who had the duroplasty had to go back for surgery, whereas 18% without the duroplasty had to go back to surgery. So now we're talking about some real significant differences. And they also found that with both types of operations, there were low rates of intraoperative complications and comparable complications beyond 6 months. So things are starting to really emerge from this. You know, when I was at Johns Hopkins, were involved in a randomized trial. So basically, patients were randomized to either getting that duroplasty or not. So those results are forthcoming. But anyway, just to kind of let you know that if you've been involved or interested in Syringomyelia research, these are some of the important things that are coming out. Okay. I wanted to spend some time talking about connective tissue disorders, and I do that because I saw some of the questions that came in. So I'll just give a few remarks about connective tissue disorders and Chiari malformation. First is that yes, there is an association. So if you were going to look at all patients with Chiari malformation who undergo surgery, there is a certain percentage who have a diagnosis of connective tissue disorder, and it varies depending upon what the study you're looking at, but it could be as low as 1% up to even up to 12%. So there's a certain number of the population has been diagnosed with this. Among this group, there's a reported higher incidence of craniocervical instability. In other words, the stability of your head on your neck, migraine headaches, and tethered spinal cord. These are by reports of people who study this. There's also the considerations for needing to do an instrumented fusion, that is fixing the head to the neck with screws and rods, in addition to the Chiari operation. And halo traction, that's a device that's placed in order to sort of stretch the neck, and done in an effort to improve the loose ligaments, the loose joints in between the head and the neck. There's surgical preservation of stability is a huge consideration in people who have a connective tissue disorder. So by doing surgery, you don't want to worsen that situation, that joint between the head and the neck. You don't want to weaken that. We know that people with connective tissue disorders do not heal well compared to people who do not. So there's obvious concerns there when you're doing surgery. We also know that there's an increased frequency of autonomic, immunologic, and systemic comorbidities, especially POTS, cardiac dysrhythmia, and gastric motility. A lot of big words there. So we know that this connective tissue disorder is connected with a lot of other what we call systemic disorders. Lots of them with big names, but it's not just a one problem thing. It does affect multiple other organs. And then we know that in this is a larger study that was that's listed down there, that looking at a national database, people who have this diagnosis tended to have a longer length of hospital stay when they were treated for their Chiari malformation, and also a higher rate of coming back to the hospital non-electively. All right, so those are also, let's go to the considerations that the surgeons and the families have to go through when there is that diagnosis. We've done some work looking at how do we improve the recovery from this. It's a big operation. Some of you may have had the operation, so and how can we make that experience better, more tolerable, and the pain that is encountered afterwards is a big deal. I'm really happy that I came across this study from 2021, came out of Oregon, looking at a standard protocol for treatment of pain after Chiari operation. And I adopted it quickly after I saw this, and I've been very happy with the results. So basically, if you give all people who get this operation a standard regimented medication afterward, you find that they tend to do very well. So this is just kind of a list of the medications that's done with this protocol, and I sort of adopted it word for word in our hospital. And what it showed was that after adopting this type of protocol at their institution, they were able to reduce the number of hours that the patients were staying in the hospital, and then finding that a lot of them were able to leave early. So that was a benefit, and I'm kind of finding some similar results at our hospital. The other thing that we implemented here was the use of an injection. This is the technical term, intraoperative liposomal bupivacaine. It's also got a trade name. It's called Exparel. This is an injection that was commonly used in other types of surgery that involve like large regions that are often painful after the operation. Well, particularly in our field, it would be used for spine surgery. And what it does, it's an injection that causes a slow release of the pain medication over time. So the thought is by around 48 to 72 hours, it's released slowly. And so we started injecting this substance into our surgical site when we did Chiari operations. And initially we found some pretty good results. So this is just like a summary of 7 patients. And, the ones who had the stars with them, they didn't use any opiate medication at all after the operation, and the other ones who did, they showed pretty low pain scores. So we got pretty excited about using this. So this is pretty standard for us when we do our operations. And then the other thing that we looked at, I think this will be one of the final studies that I'll talk about, is what about fusion? So what about the need to fixate the head to the neck with screws and rods? We hear about that, and we think that one of the big concerns when I started working in pediatrics was, are we doing something bad by doing the operation, and are we making that joint weaker? And how many of these kids are going to eventually need something to help fixate the head to the neck because we made the joint weaker? So I asked that question among our patients in our hospital. And we looked at our population, and this is an X-ray here on the bottom right of a patient who did end up getting that screw and rod. So that kind of gives you a visual of what's done there in order to strengthen that joint. And it turns out that that the rate of needing that was very low, at least in our experience. So we looked at 30 kids who underwent Chiari operation, and we followed them, all these for a long time. And we found that only one required a fusion. So, we kind of walk away from this thinking that, as much as we worry about weakening that joint between the head and the neck with surgery, it really is a very low risk. And that one that required a fusion was a very particular case. But overall, I can comfortably counsel our families that that's a very low risk when we walk into this with kids. All right. So, that's kind of a summary of all of um, our work, at least in the recent years, in terms of improving things. And, overall, I just wanted to kind of touch on, how it is that I enjoy doing this, is because, we have a lot of success stories, in working with families and, people who've been suffering for years, and being able to witness them come out of this and to get better, get back to the things that they want to do. I mean, it's a complete treat for me to be able to do this. However, it's not all success stories, as we know. There are surgical complications. This is a very complex disorder, and the surgery is good, but it's not perfect by any means. And one of the things that one of the cases that I'll never forget, that really kind of spurned me to dedicate some time to this, was someone that I treated not too long after I arrived at the Mayo Clinic. And this is one of our guys from another state who came in, and forgive the text here, but I'll just read through it and just tell you his story. So he's a 17-year-old male, and he was found to have a Chiari malformation after he had a concussion during a high school football game. And then he was relatively okay after that concussion, but then later he started to develop severe head pain and numbness. And then he underwent a surgical decompression at another hospital. This is when he was 17. He had some problems with that surgery. It was complicated by an internal CSF leak, and then he later developed like this back pain that he never had before, and the back pain extended down to his legs. And then he had to go into rehab because the back pain was so bad. And then he was found to have this condition, arachnoiditis, which, personally, I've never seen in relation to a surgery like this. But this arachnoiditis, I'll explain what it is scarring within the spine. So basically, he something about the surgery up in the brain kind of like translated all the way down into his spine, so that the nerves in his spine were all scarred. And then he was suffering with really severe back pain and unrelenting, really. He kind of lived with it, did a long inpatient stay. He eventually got into college, and then by the age of 20, he came to us, and he was reporting really persistence of pain in the back of his head, especially with strenuous activity or coughing or sneezing. He was unable to really attend classes full time. I mean, he basically got to the point where he had to drop out. The brain MRI showed recurrence of compression at the surgical site. The spine MRI showed pumping of his nerve roots, which was consistent with arachnoiditis. And I'm going to show you his MRI scan. So basically, this is when he was first diagnosed after a concussion. You can see the Chiari malformation, pretty full back here. Didn't get treated at that time, but then a couple years later, he did get treated with a surgery. And what we're seeing here is that a surgery was done, that a portion of bone was removed, but then there's like all this fluid buildup inside. And this is a complication. This is really CSF, what we call a CSF leak. So the surgery was not smooth. He had an extended recovery, had to go back to the inpatient rehab. And then when he came to us several years later, this is when he's in college, what we found is that fluid spontaneously went away. They didn't have to drain anything. Eventually went away, but what he's left with is really no room at all. So he's got some missing bone back here, but really no space around his brain. So everything just kind of like scarred down. And this is not what we want to see after surgery, very unusual. And then when you take sort of a cross section through his back, you can see individual nerve roots. So this is a kind of near his upper back, where you see all these little dots, which are individual nerve roots. That's normal. That's what you should see. But then when you go farther down into his lower back, they're all clumped together, and that's not normal. That's what the condition arachnoiditis. And this guy really was struggling with pain up in the head, but also really this chronic back and leg pain. So we offered to bring him back to surgery. So we did a revision surgery, and what I found in the operating room was that there was layers of thick scar. So we did a revision of the covering over top of the brain, the duroplasty, and then I placed a plate because he needed some more support over the skull. So that was done, and one of the biggest treats in seeing him through this was that I was able to reconnect with him, and a year later he has experienced complete resolution of the head pain. So from the day that we did the operation, the head pain went away. He has returned to college full time, and he's studying to become a science teacher. He's tolerating all activities, including lifting weights and running, and he still requires um, uh, pain specialty visits for his back and arachnoiditis. But we're able to kind of see him through that. And this is the MRI before and after. So this is when he came into us, like really everything just kind of really socked in and compressed. And it doesn't look like a lot, but we made some room around his brain, and that was enough for him to feel a lot better and go back to what he needed to be doing 3 months later. So it was a treat for us, but just kind of a reminder that this isn't smooth sailing for a lot of people, and there's a lot of work yet to be done to improve things. All right. So I will finish things up. I did want to say a few words about the Bobby Jones Classic. We talked about that earlier, but it is a complete joy for me to take this time. It's usually around April, and we go out there. And for the past several years, it's been at East Lake, which has been a dream for us. So the first year I went out with three of my neurosurgery colleagues, and we had a blast and had a foursome. We actually will, for some bragging rights, we did win that year, and I was able to earn my East Lake jacket. Obviously, 2020 we had to skip it. 2021, I brought along my son, who's a junior golfer, standing next to me. We were playing, fortunate enough to be playing with Brian Katrick, who announces the golf matches on PGA Radio, and Bob Jones the fourth, who's the grandson of Bobby Jones. So we were able to play together. 2022 brought again my son. You can see he's getting bigger, and Bob Jones the fourth, and had a great round there. And this is just one of the things that just one of these memories that you cannot replace. And one of the challenges there is for one of the holes, they give us hickory shaft golf clubs, which are similar to the ones that Bobby Jones used. And so you had to hit the ball to the hole with hickory shaft golf clubs. Most people do horribly with this challenge, but this is a picture of my son on this challenge here with the hickory shaft golf club. Can't really see the ball, but it lands right on the green. So anyway, yeah, just a lot of good memories that this event brings every year. So you can't really replace it. This was us at the last event, 2023, with Brian Ketcherick and his son, and then another father-son between me and my son. So anyway, this is just something I look forward to every year. And really thank you guys for paying attention, and thank the folks here from the Bobby Jones organization to set this up every year. All right, well, I will stop sharing, and hopefully we have some time for some questions.
Yes. I did want to quickly start with a question that came in the chat because it was relevant to one of your presentations. That study that you did with the 30 patients about requiring the fusion, or rather not. Did you account for connective tissue disorders? I assume you did, but in the descriptive statistics.
Yeah, none of them had a connective tissue disorder. So yeah, we did look at that. Turns out that none of them had that. So I would suppose that probably the incidence of that will be higher for people with that disorder. But yeah, we didn't have any patients with that.
I'm going to do one of the questions that came in earlier. Basically, what is the likelihood that a hypermobile child would go on to have Chiari-related symptoms? So I'm assuming that they have an incidental Chiari on an MRI. They're not having any symptoms right now. What's the mechanism, in hypermobile or not, actually? What's the mechanism that those symptoms start up later on?
So there's possibility of that for sure. We talked about children changing, with time. So, some of the studies that I showed that certainly Chiari could get worse with time, with changes. And we know that with hypermobility, there's a couple other factors that complicate things. Is that there's this idea that the head sort of settles on the spine, just like a house settles on the ground. So you could see that over time. So as the head sort of settles on the spine, there could be less room back there. So just extra vigilance with people who have that disorder, even though they're asymptomatic, might be worthwhile to be extra vigilant for symptoms, and maybe even do another MRI down the road.
There was a good question, and this comes up a lot with people who call in. So a patient with a cervical syrinx, so they're saying 7 millimeters, which I assume is pretty wide. They have a normal neurological exam. They're not experiencing any symptoms. How would you counsel a patient that comes in like that? Would you necessarily want them to have surgery, or is that a patient you kind of wait and see?
Yeah, I think I'm very honest with the families. What we have in terms of evidence here is not really decisive. So I showed a couple pictures earlier in this presentation of the syrinxes that just go away naturally without surgery. So you can't argue against that. I mean, there's no surgery and kind of goes away with growth. Um, so just very frank with the families that we don't have an answer to this. We don't know which direction it's going to go. I will say that probably, in that particular situation, 7 millimeters is not certainly not on the large side. It's kind of on the sort of medium small size. So with that family, I'd probably discuss, yeah, you have an option of just kind of watching this. Maybe we can do another MRI a year later and see how things come about if there are no symptoms at all, right? So I think that's a valid question. We do have a fair number of families that feel like, whoa, I don't want to even take the chance of something happening. And we're talking about the spinal cord. We're talking about, functioning of the arms and legs, and I don't want to take that chance. So let's just get this done, And I think that's reasonable also, So I just try to do what works best for the family. People have different. I like to think people have different tolerance for something kind of brewing, and some people are just like, just get it done and let's get on with it. Or others are just hey, let's be cautious about this. And I like to work with the families, whichever direction they like to go.
Sure. I know I'm very risk averse, so I get
Yeah.
that. Actually, a follow up. If an MRI is showing, this is a Chiari, showing a Chiari in maybe a hypermobile connective tissue patient, is there the suggestion is there anything that someone can do to prevent becoming symptomatic? I'm sorry, I'm having like a rough. How can there's something that they can do to prevent symptoms?
I don't know. I think that what I would do is hook in with a really good, obviously a really good surgeon, but also a really good geneticist, because there's probably some work done there. I mean, this is a very complex disorder, and there's a lot of sort of unknowns about it. So I would say, hook in with a good team. The surgeon is probably your last resort, but then there's a whole team of physicians, and I would say a geneticist would be really instrumental there to think about, is there anything that we can do to slow this process down?
To that end, another question came in about the kind of mechanism of so the CSF fluid dynamics and um, what's the role or the mechanism of that in developing those later onset like hindbrain herniations in adults if they have normal skull size shapes there's no if they weren't congenital and they didn't experience any traumatic injury that they know of. Is there something that the dynamics are doing to kind of cause that problem, or is it structural?
So we're talking about, just gonna kind of want to clarify. Do you think it's like people who get the Chiari later,
Yeah.
or
Yes.
okay,
And
yeah,
they
we don't.
weren't born with it or anything like that. Yeah.
They weren't born with it, but then they get it later. We don't know. Yeah, we
Yeah.
don't know why that is. So the sort of the holy grail would be, if we had gotten some pictures, MRI scans of when they were younger, and I have seen that situation. I have seen, through my practice, seen you know older children come in with Chiari malformations, and then there's been a handful of times where we do have that MRI when they were born. For whatever reason, they got one, and there was no Chiari malformation. So we don't have an answer as to why it develops over time. It's something about the way um, the sort of distribution of the way the skull grows, and I think it has to do with, kind of a smaller uh, posterior or, back of the skull, but just don't know why it pops up later in life.
Yeah.
I
To
hope
that,
I hope that helps. Yeah.
yeah, a question came in about how syrinxes are kind of formed. So how does the CSF get into the cord like that? Do they know?
So yeah, no, there's no definitive evidence there, but basically the thought is that it sort of pulses into the spinal cord from an area that where the spinal cord starts, way at the top, and and there's an opening. Basically, it's microscopic. There's an opening into a cavity into the syrinx called the obex, and some people think that the fluid can kind of pulse its way through that tiny opening and then eventually dilate the spinal cord.
I'm trying to do these rapid fire, at least some of the ones that came in, so we can keep on time. But was a question about that I thought was interesting the way it was posed. So they talk about how things are scaled up and down for dosages on prescription medications based on BMI and weight. Um, and the question was sort of, are there any specific measures or tests that are done in Chiari care that might be influenced whether someone is maybe a child versus a teenager or an adult? Are all those measures the standard done throughout life, or are they done differently in smaller bodies, I guess, little ones?
Um, so yeah, definitely measures are done. I'm just trying to think here
Yeah.
with regard to um, treatment. So probably nothing kind of similar to the way medications dosed. I don't think anything like that. Um, uh, I will say that that we try to, the treating surgeons probably differ in, you know, the type of operation that they do and, how much bone is removed. So nothing standardized with respect to that, but they probably do adjust it for when the child is smaller versus bigger. I know I do, for sure. The operation I do on a child is different than what I would do on an adult. It's just in terms of, scaling it down for the child. Um, and then I think that, in answering some of the measurements that are done, yeah, there's a lot of measurements that are done because not all Chiaris are the same. And some of them can be, for example, some of them can herniate, some of them can be compressing or herniating more than others. So that's measured. The other thing that's different is like kind of the angle on the head on the spine. That'll influence a lot of things, right? So all those things are measured. I take time to measure those just to kind of guide me in what the best treatment is.
You had mentioned that new uh, way that you were doing the incision. So a question had come in about, are there any alternative options besides a posterior fossa decompression and duroplasty in general that would help treat these symptoms, or is it strictly? They were really asking as far as minimally invasive surgery is concerned. I
Yeah,
don't think there's anything about the surgery that is minimally invasive, but
yeah, I've thought about that a lot. A lot. Obviously, the trend is for a lot of operations to become minimally invasive, and I've read a couple reports of people who get like a really small incision, and then we can kind of go into that area of the spine or the brain with a small tube, and just kind of do the operation through the tube. So I've thought about that, and I would say that it's not routinely done at every hospital, but there are some people who've tried that. And I do, every time we think about doing something minimally invasively, we always have to think like, is this getting the same effect as if we were to do the minimally invasive surgery? And I still haven't gotten to that point in my mind where I can do all the same things with the same risks minimally invasively. So I have not kind of reached that, and I thought, at least in my thinking, well, the best I could do now is at least let's hide the incision, right? So then at least that part is better. But in terms of like going through like a tiny tube or a scope or something like that, it's not standard yet.
right. Um, and there was a question about what to expect after surgery. We get this question a lot too. And you mentioned it a little bit in the regimen that you talk about with the medication, but what does recovery usually look like? And then um, past that, how long does it usually take for those symptoms to get better? Do they ever come back? What does recovery look like?
Yeah, I usually tell the kids at least that expect probably around 3 days, 3 or 4 days in the hospital. I've been finding that with the interventions that I talked about, it's often 2 or 3 days, but I kind of, I'd like to kind of, um, I guess, under promise and overperform that kind of thing. So I'll tell them 3 to 4 days, but more commonly 2 to 3 days. That's in the hospital, just to kind of get the pain under control and feel like you can, just kind of lounge at home after that. And then I will say that, I deal mostly with kids that they're usually back in school somewhere around 2 to 3 weeks. so they're able to kind of at least go part-time or full-time back to school within 2 to 3 weeks. I do tell them to lay off of like strenuous activities. So if they're involved in contact sports or volleyball or whatever, they have to not do that, and that is primarily to make sure that the duroplasty heals. I generally use duroplasty, so make sure that heals. The symptoms can go away. I would say that by the time I'm talking to them in about a month, usually the symptoms have either gone away or almost gone. So I'd say about a month. Can the symptoms recur? Yeah, sure. I mean, there could be recurrent symptoms from the Chiari malformation. I rarely see it with doing the duroplasty. I feel like that it's just very unusual for that to happen, but theoretically there's a chance that something like that could come back.
Sure. And then if you'll indulge me on this last question that came in because it is good. Is there such a thing as too late for surgery? I assume in Chiari or Syringomyelia, probably more Syringomyelia, but at what point do you think there are permanent effects? And then would you ever operate before symptoms appear to avoid that kind of permanence?
Yeah, so the answer is no. I don't think there's a too late for surgery. So we have seen with syringomyelia, some of the patients come in, they've already lost some muscle in their hands. They've already lost some function, and I never say it's too late. So routinely I do see some improvement even after they've had that for a while. So yeah, definitely don't. I don't think it's too late, and especially I tell them that we got to halt this. We got to stop the progression. So yeah, I don't think there's any too late for that. And then yeah, in terms of the syringomyelia, for sure, if it's there and yet the person doesn't have any symptoms, we're often suggesting to be upfront about it and to be proactive and to go ahead and to make things better before there's any problems. So that is a common type of decision people have, and I think it's worthwhile many of the times. But as we said before, sometimes they go away naturally. So um, yeah, it can go both ways.
Yeah, that's the worst part of it.
Yeah,
Uh, but I do want to keep us to the hour to respect your time because I see you at work. So I wanted to thank you very much, Dr. An, for doing this with us tonight, and thanks everyone for joining. If I didn't get to your questions, I promise I will try and get them to the next session. But thank you so much for being here with us today.
absolutely. Yeah, keep doing such great work there. And I really want to congratulate you guys.
Oh, you
This is
too.
wonderful. Yeah.
Oh, yeah, awesome. Thank
All
you.
right, guys. Yeah.
Thanks, everyone. Good night.